Hello class, today's objective revolves around the science of arthrokinematics. We are going to discuss in further detail the importance of row end genograms and deformities on joint motion and functions. Let's first look at two row end genogram views of the wrist. Okay, first, let's look at the PA view, or the anterior posterior view. As I describe this in better detail, please refer and look at the diagram on this slide. We can determine the radial height, the distance between two parallel lines drawn perpendicular to the long axis of the radial shaft. One line from the tip of the radial styloid and the other from the ulnar corner of the lunae fossa of the radius. This average radial height is established to be at 12 millimeters. We can also establish or assess the amount of radial inclination or radial slant, so to speak. Radial inclination is the angle between two lines. Okay, one is drawn perpendicular to the long axis of the radius. So picture a vector going through the long axis of the radius. At the ulnar corner of the lunae fossa of the radius and the other between the point in the lunae fossa and the tip of the radial styloid. This has an average angle of 23 degrees. Lastly, we can look at the amount of ulnar variance associated with the PA row and genogram view. This is the measurement of the relative lengths of the radius and the ulna of the wrist. This is the distance between two parallel lines drawn perpendicular to the long axis of the radius at the distal articular surface of the ulna and the ulnar corner of the sigmoid notch of the radius. 60% of the population do have an ulnar neutral position. Now, let's look at the wrist from the lateral view. We can detect the amount of radial and or palmar inclination and the scapholunate angle. However, first or foremost, for the purposes of this class, let's just focus on the radial or palmar inclination. This is also the angle between two lines, one drawn perpendicular to the long axis of the radius, and the other between the dorsal and palmar lips of the distal articular surface. The average of this angle is 12 degrees. Evidence does reveal that the amount of palmar inclination, if it is greater than 20 degrees, it will limit wrist flexion. This is important to know when it comes to educating patients on outcomes post a distal radius fracture. Evidence also reveals that a successful outcome following a distal radius fracture is a return of 80% of range of motion as compared to the non-involved wrist. So let's put these views to use. When the radius sustains a fracture and the individual undergoes a reduction in immobilization or even an internal fixation with mobilization, it is imperative that the anatomical features of the radius and wrist remain within a normal limit or accepted values established through evidence. So upon reduction, the physicians are looking at the amount of radial tilt, radial inclination, and radial length on the row end genograms. Again, normal values for palmar tilt of the radius is between 10 and 15 degrees with an average angle of 12. And the normal values for the radial inclination or radial slant is established at 20 to 25 degrees with an average of 23 degrees. Here, as you can see, is a normal palmar tilt at 11 degrees. To note, students, and of importance when you're treating someone with a distal radius fracture or disturbance to the anatomical features of the radius, a loss of palmar tilt will equate to pain at the radiocarpal articulation It can also cause a decreased grip strength and a painful grip, and also it can cause a substantial or significant loss of palmar flexion, which could be up to a loss of 20 degrees of wrist flexion or more depending on the amount of dorsal tilt as compared to the normal palmar tilt measures. As previously established, the normal radial inclination is said to be between 20 and 25 degrees, with an average of 23 degrees. A loss of the normal inward tilt of the distal end of the radius could present the client with, number one, limited ability to deviate ulnarly, so they have a loss of ulnar deviation. And two, they could have increased loading of the lunate, resulting in increased likelihood of radiolunate arthritis. The radial height can pose many problems for the clients, especially if the ulnar variance is not considered neutral. That is considered 10 to 13 millimeters of variance. So there are two important factors associated with this concept of radial height. One concept is the ulnar variance or negative variance. The other is ulnar impaction or a positive variance. Now, if someone is established to have a ulnar variance, a negative ulnar variance, this can lead to you treating a client with undiagnosed wrist pain. So you get somebody come into the clinic or into your facility of undiagnosed wrist pain. You want to try to roll out through special orthopedic testing if they have any kind of ulnar variance. Two, they can present to you with decreased wrist flexion, and they can also present with limited wrist motion, all related to an ulnar negative variance. Fourthly, they can also present with a Kienbock's disease, or maybe they're even diagnosed with Kienbock's disease. You may have never heard of this term before, but Kienbock's disease is actually an avascular necrosis of the lunate, which is initially characterized by pain, stiffness, and swelling. This is usually caused by like a nutcracker effect, where there's increased pain or increased pressure from the lunate fossa of the radius onto the lunate. On the other hand, if you have ulnar impaction or ulnar plus variance, this can lead to a painful grip, a lessening of pain if you perform a grip in a supinated position. This is due to the fact that if we are performing a grip with with the forearm in a supinated position, it actually decreases the force on the ulnar carpal side, and thus not provoking as much pain in the wrist. We'll also have a painful wrist extension, and we'll also have pain during any kind of weight-bearing activities. And finally, you will also note with ulnar impaction, ulnar-sided wrist pain in most of these folks. The best design for ulnar impaction or ulnar positive variance is what we call the lion's paw, as you can see illustrated here. You may have already observed a wrist status post distal radius fracture like this illustration. However, this may be a good visual for you when evaluating a client with a distal radius fracture and determining if he or she needs further care. So in summary, I hope I met and or exceeded your needs necessary to increase your base of knowledge in wrist arthrokinematics and why such arthrokinematics are important in functional outcomes following disruption of the radius. Thanks.